Hello everyone, welcome to POC Nurse. My name is Gozi, and in this video we're going to discuss oxygen delivery and utilization in the critically ill. This is for the CCRN exam, for the pulmonary section of the CCRN exam to be specific. So for a patient to be adequately oxygenated, oxygen has to go from the level of the lungs all the way down to the cells, meaning a patient has to breathe in the air and that air has to travel uninhibited, unimpeded to the cells, and then the cells have to be able to take up that oxygen and utilize it with no problem. Then we have adequate oxygenation. Anything that affects the oxygen going from the lungs to the cells, anything that affects uptake of oxygen by the cells will affect oxygenation, proper oxygenation in the patient. So for adequate oxygenation to occur, first of all, there needs to be adequate ventilation, meaning the patient has to be able to breathe in all that air without any obstruction. Secondly, gas exchange has to happen at the level of the alveoli and the pulmonary capillaries. Third thing is that as gas exchange occurs between the blood and the alveoli, hemoglobin is needed to pick up the oxygen and transport it to the tissues that need it, obviously. And for the blood to reach where it's going, we need a pump, the heart. So cardiac output needs to be adequate for the blood to reach its preferred destination. And then when the blood gets there, when the hemoglobin carries the oxygen to the tissue that needs it, hemoglobin needs to be able to release the oxygen and not hold on to it so that the tissue can use it. And when hemoglobin finally releases the oxygen, the cell itself needs to be able to pick up the oxygen and use it to create energy in aerobic um, respiration or aerobic metabolism. So in aerobic metabolism slash respiration, glucose is broken down in the presence of oxygen to produce ATP, the energy molecule needed to drive the processes in the body. In the absence of oxygen, we have anaerobic respiration or anaerobic metabolism. In this case, glucose will still be broken down, but in the absence of oxygen, and this is where you have the production of lactic acid, where there is no oxygen for the most part. There are different reasons why the body creates lactic acid, but in this case, when we talk about respiration, when there's a lack of oxygen, um, the body switches over to anaerobic metabolism, and lactic acid is one of the byproducts of that process. There are different parameters that are used to measure oxygenation in a patient, and it's important to know what they are and their normal values and the letters, so to speak, that represent them, because you might see it on an exam and it's important to know the significance of it, what it means to you per answering that question. So if the question gives you like an SVO2 of whatever number, you already know, okay, that's mixed venous blood. That is oxygen attached to hemoglobin plus oxygen dissolved in venous blood. So blood that you typically find in the right side of the heart. So if it's too high, you're going to be like, oh, the tissues are not using the oxygen. Why? So it's important to know the significance of each of these parameters. We're going to go into that next. First, we're going to talk about PaO2, which is one of the values you see on that ABG paper when an ABG is run. So PaO2 is the amount of oxygen that's dissolved in blood. So it's not the oxygen that's bound to hemoglobin, just the amount of oxygen that's dissolved in arterial blood. The normal value for that is 80 to 100 millimeters of mercury on room air. So now if a patient has less than 80 millimeters of mercury of PaO2, this person is hypoxemic. Patient has hypoxemia. Now, the next parameter we're going to talk about is saturation of arterial oxygen, SaO2. Now, SaO2 is 95 to 99% normally on room air. and it is the amount of oxygen that's bound to hemoglobin in arterial blood, right? So now we're going to talk about mixed venous oxygen saturation. So mixed venous oxygen saturation, the normal value for that is 60 to 75%. It's represented by SvO2. So like we said before, you get this number from venous blood, that is blood that's in the right side of the heart. And it's the most sensitive indicator of oxygenation at the cellular level because remember, this is blood that's returning to the right side of the heart. So if all of the tissues have picked up enough oxygen that they need, when that blood returns to the right side of the heart, the percentage of SVO2 we should have should be 60 to 75%, which is normal. That means the tissues have been well oxygenated, they've taken as much oxygen as they need, and the venous blood is now going back to the heart to pick up a new batch of oxygen. So if it is too high, the tissues are not using enough oxygen. If it is too low, the tissues are using too much oxygen. So the question then is, what's going on? We're also going to talk about oxygen content. This is CaO2. So CaO2 is the PaO2, the amount of blood dissolved in the oxygen, and saturation of arterial oxygen. So the amount of blood dissolved in the amount of oxygen dissolved in the blood itself, and the amount of oxygen that's bound to hemoglobin. So the normal value for oxygen content in the blood is 15 to 20 mLs per 100 mLs of blood. So it's important to know all of these values. So when you see abnormal values on the test, you can, say, oh, this is not a normal value. Or if you see a normal value, like no biggie, you keep reading the question, looking for all the clues. Um, oxygen delivery. Oxygen delivery is DO2. This is a function of cardiac output. So oxygen delivery is basically moving the blood from, the pulmonary circulation after it gets oxygenated and taking it all the way to the tissues. So anything that affects cardiac output will affect oxygen delivery. Also, anything that affects the amount of hemoglobin in the blood will also affect oxygen delivery. So if there's not enough hemoglobin, if the patient is severely anemic, the tissues are not going to get enough blood because there's just not enough hemoglobin to carry the oxygen. I mean, the tissues are not going to get enough oxygen because there is not enough hemoglobin to carry the oxygen back to the tissue. Normal value for oxygen delivery is 9 to 1100 mLs per minute. Next, we're going to talk about oxygen consumption or oxygen utilization. That is actual use of the oxygen by the tissues. In the normal value for that is 250 to 350 mLs per minute, and consumption or utilization of oxygen is usually low in sepsis when a patient has septic shock. And that makes sense because there's hypoperfusion in septic shock. Um, we're also going to talk about the alveolar arterial gradient, which is the big A minus a small a, with the big A representing the alveolar portion of this equation and the small a representing the arterial portion of this equation. The normal value is less than 10 millimeter of mercury, and it's pretty much the difference between uh, the partial pressure, I believe, of oxygen in the alveoli and oxygen in the arterial system. So this tells us whether there's normal transfer of gas. I believe at the alveolar bed, so between the alveoli and the pulmonary capillaries. So essentially, well, usually when we have our patient and we're at the bedside, we're pretty much looking at the O2 sat. That's the external measure of how much of the hemoglobin is bound to oxygen. When we do an ABG, we get the SaO2, we also get the PaO2. So usually we rely on those things that we easily get to see how adequately the patient is being oxygenated. And in this chapter of the book, we're getting other parameters that we can use to see how well oxygenated a patient is. And the importance of these is that it might come up as part of the vital signs, so to speak, of the patient. So if you don't know what it is, it's going to be difficult to know what the question is asking and then to answer the question. So I think that's why it's important to know the normal values for these parameters and their significance when it comes to oxygen delivery in the body. Because remember, not only does oxygen have to go from the lungs to the tissues also have to be able to use the oxygen, take up the oxygen, and hemoglobin has to be able to release the oxygen. So in that case, we're not only talking about just the patient's O2 sat, PO2, SaO2. We have to talk about factors that could affect the delivery of oxygen at any point and even the utilization of oxygen by the tissues as well. We're now going to discuss the oxyhemoglobin dissociation curve, and we've all heard about this during orientation for the ICU I did. So it basically is um, explains if hemoglobin is releasing oxygen readily or holding on to it, and this will affect oxygenation. So if hemoglobin doesn't release the oxygen, there'll be inadequate oxygenation. Now, if the hemoglobin um, is releasing too much oxygen and not being able to pick up more oxygen, it will affect oxygenation. So let's talk about the movement of this oxyhemoglobin dissociation curve to the left or to the right. So anytime something moves to the right, think the right things are happening. So when this curve moves to the right, hemoglobin is releasing oxygen, which is what it should do because the oxygen is needed by the tissues for aerobic metabolism or aerobic respiration. Now, the thing we need to know is what conditions cause the curve to move to the right. So acidosis will cause this curve to shift to the right. A high PaCO2 will cause the curve to move to the right. A fever will cause the curve to move to the right. If a patient has a high 2,3-DPG content, then hemoglobin will have less affinity for oxygen and release oxygen very easily. Now, this 2,3-DPG is an organic phosphate and is found in red blood cells. This is how it affects the oxyhemoglobin dissociation curve. So now in the case where this curve has moved to the right, the patient will have a low SaO2. Remember, SaO2 is the number of hemoglobin attached to oxygen. So if the curve moves to the right, hemoglobin is releasing oxygen very easily, very fast. So that means there will be less hemoglobin holding on to oxygen. So SaO2 will be low, but the tissues are getting well oxygenated because oxygen is being released readily by the hemoglobin to the tissues. Now, when this curve moves to the left, that's what we don't want to happen. When it moves to the left, that means hemoglobin is not releasing oxygen, it's holding on to it tightly. So, things that can cause this: alkalosis, a low PaCO2, hypothermia, and low 2,3-DPG. So when these when this organic phosphate 2,3-DPG, also known as 2,3-diphosphoglycerate, when it is low, hemoglobin has increased affinity for oxygen, so it picks up oxygen very easily, doesn't let it go. Okay, so that's it for the oxyhemoglobin dissociation curve. For the exam, you just need to know the conditions that cause it to shift and what actually happens when it goes left or right. I think I got one question on that. I didn't really study it, so I don't think I need the answer to that one. So it's something that you should know and just memorize. You know, it'll help. So in the case of a shift to the right, the tissues get the oxygen very easily. But in the case of a shift to the left, the tissues don't get the oxygen very easily. But SaO2 is going to be high on this patient. It's going to look nice on paper, but the tissues aren't getting oxygenated. We spoke about the 2,3-DPG earlier, also known as 2,3-diphosphoglycerate, as an organic phosphate found in the red blood cells that alters hemoglobin's affinity for oxygen. So when this 2,3-DPG is high, hemoglobin has less affinity for oxygen. In this case, the dissociation curve moves to the right. Less affinity means hemoglobin gets rid of oxygen very easily. Now, when the 2,3-DPG is low, hemoglobin has increased affinity for oxygen, so it holds on to oxygen longer, more readily, and does not let it go. So that this is how 2,3-DPG affects oxygenation. Conditions that can cause decreased 2,3-DPG levels are hypothyroidism, hypophosphatemia, and a condition where someone's getting multiple blood transfusions. Things that can cause increased 2,3-DPG: hyperthyroidism, anemia, and chronic hypoxemia. Next, we're going to talk about something that prevents the use of oxygen at the tissue level. We're going to talk about carbon monoxide. So, carbon monoxide has a very high affinity for hemoglobin, even more than oxygen. So, the affinity carbon monoxide has for hemoglobin is 230 times that of oxygen. So, carbon monoxide will bind to hemoglobin more readily than oxygen will. So in a case where carbon monoxide is present and has bound to the hemoglobin, oxygen cannot bind, which means there is no delivery of oxygen to the tissues, only delivery of carbon monoxide. And a pulse oximeter can give us an accurate O2 sat in a patient that has carbon monoxide poisoning. Because when you put the O2 sat on the patient and all of the patient's hemoglobin is 100% saturated by carbon monoxide, that patient's O2 sat is going to be good. It's going to be very normal. However, the patient is not getting any oxygen, is not transporting any oxygen. Patient is instead transporting carbon monoxide. So if you have a patient or you have a question about carbon monoxide poisoning, using O2SAT on that patient is not realistic. It's not going to give you an accurate idea of what's going on with the patient because it measures CO2 the same way it measures oxygen. I mean, it measures carbon monoxide the same way it measures oxygen bound to hemoglobin. So if a patient has a 40% level of carbon monoxide bound to the hemoglobin, then that patient can only now carry 60% oxygen because only 60% of the hemoglobin is available to pick up oxygen. Now, there are different symptoms or clinical presentations associated with the amount of carbon monoxide that a patient has in their system. So, 0 to 5% carbon monoxide content is normal. There will be no symptoms. Less than 15%, we all usually get in people that smoke and people that drive trucks, probably because they're usually exposed to carbon monoxide. Now, when we start getting to 15 to 40%, we start getting some neurological symptoms, such as a headache and some confusion. At 40 to 60%, we have loss of consciousness and Cheyne-Stokes respirations. Hopefully, I pronounced that correctly. It is Cheyne, Stokes respiration, Cheyne-Stokes respiration. At a 50 to 70% content of carbon monoxide in the blood, mortality rate for that patient is greater than 50%. So this carbon monoxide is really a lethal poison. And another thing I read somewhere is that it also actually prevents the mitochondria from oxygen uptake. So, in the presence of, I think, probably a lot of carbon monoxide, the mitochondria actually cannot take up oxygen so that aerobic respiration can occur. That is the Krebs cycle. So, it is really a deadly poison. Carbon monoxide has no smell, can't smell it, and the symptoms are so insidious. You have a headache, you're a little bit confused, nobody thinks anything of it, but long term it has very devastating effects even after it's treated. Now, speaking of treatment for carbon monoxide poisoning is administering 100% FiO2 of oxygen until the symptoms the patient is presenting with have resolved and the level of carbon monoxide bound to hemoglobin is less than 10%. Sometimes treatment could be a hyperbaric oxygen chamber if it's available and should be administered within 30 minutes. I think that helps push out the carbon monoxide from the hemoglobin, and oxygen will readily bind to the hemoglobin. Another poison I read somewhere that could affect the utilization of oxygen. That is, this oxygen has traveled all the way from the lungs down to the tissues. It is there at the tissues, but the tissues cannot use the oxygen. Cyanide poisoning. Cyanide prevents the use of that oxygen that was delivered to the tissues. So that's why when we talk about oxygen delivery and utilization, even though the oxygen can go very nicely from the lungs all the way down to the tissues, there are still things that could prevent the tissues from using the oxygen, such as toxins like carbon monoxide, like cyanide. Now we're going to talk about lung compliance, because lung compliance also affects oxygen delivery and utilization. Lung compliance will become a factor when we talk about ventilation. So, when we think about lung compliance, we're thinking about static compliance and dynamic compliance. Static compliance is a measure of the elastic properties of the lungs itself, right? Here we're talking about tidal volume divided by plateau pressure. So if there is an increase in plateau pressure, there will be decreased compliance. So I think of plateau pressure as kind of the resting pressure of the lungs in my mind. So if the resting pressure is high, compliance of the lungs will fall. Because anytime there's high pressure, it takes more energy to push at something. Let's say you have a brick wall and an elastic wall. There's higher pressure in the brick wall than the elastic wall. You push on the brick wall, less compliance. Push on the elastic wall, more compliance. So the higher the plateau pressure, the less compliance we have. Dynamic compliance, on the other hand, is a measurement of the elastic properties of the airways. Static compliance was a measurement of the elastic property of the lungs. Now we're talking about the airways. So dynamic compliance of the airways is tidal volume divided by peak inspiratory pressure. An increase in peak inspiratory pressure will decrease compliance. So it seems like anytime there's increased pressure of the peak inspiratory pressure or the plateau pressure, there's decrease in compliance. You might just get a question that says, oh, there's an increase in plateau pressure. How will it affect compliance or if it will affect compliance at all. This is something that you could just answer right off the bat. Increased pressure, decreased compliance. For both peak inspiratory pressure, PIP, and for the plateau pressure. The normal value for both dynamic compliance and static compliance is 45 to 50 mLs per centimeter of water. Patients that have pulmonary diseases that involve the airways, such as asthma, usually we have a decrease in dynamic compliance. That's we're talking about the airways because asthma is a disease of the airways for the most part. We have constriction of the airways. So in these patients, there is a decrease in dynamic compliance, but their static compliance remain normal for the most part. Now, in patients with pulmonary diseases that involve the lungs, such as pneumonia, acute respiratory distress syndrome, ARDS, they have a decrease in static compliance. That is, the lungs are not compliant, but their airways, their dynamic compliance could also decrease because the lung pressure could get transmitted up, to the airways as well. Therefore, compliance in everything is decreased. That's why when you have the ARDS patient, it's difficult for them to oxygenate because their lungs just isn't responding to all the oxygen it's getting. It's harder to oxygenate those patients. Okay, moving on. The significance of this compliance, apart from the fact that it affects oxygenation, adequate oxygenation, um, when there's decreased compliance, a patient has to work harder to ventilate, to pull in air. Because when the lungs are non-compliant and stiff, they don't expand very well. So the patient has to breathe in harder, use more muscles to pull air into the lungs because just decreasing the pressure in the chest is not enough. It's even hard to do that because they have to move their chest walls, move the lungs to create the volume for air to rush into the lungs. This is where we're going to end this portion of the CCRN review for pulmonary. We talked about oxygen delivery and utilization in the critically ill. We talked about parameters we could use to determine if a critically ill patient is getting adequately oxygenated or not. Some of these values you can find on the acid base when you do an ABG, and that's what we'll talk about in our next video. I hope you found this video helpful, and I'll see you in the next one. Bye bye.